can't see the people attending because I guess it's on my share screen because I have it in full slide mode. But just holler if you have a question. You can stop me anytime. So there's the things I wanted to really touch upon in the field of CF is the basics that comes to diagnosis. And how to manage CF patients with advanced lung disease. So it's a completely two opposite ends of the spectrum. Sometimes it's the same spectrum because it could be someone who hasn't been diagnosed up until they've reached advanced lung disease, or it could be someone on the older side with advanced lung disease versus someone who um, of we've had a handful of younger people in their 30s that the diagnosis wasn't made until they've reached young adulthood. Um, so I think that these are two major topics that I think everyone would benefit from, whether or not they go into CF um, as a subspecialty. As part of tonight's talk is basically recognizing the workup for CF, managing after diagnosis, long term care of CF, especially with the newer drugs coming out, and again, advanced CF lung disease. So, this is patient one. It could be any of the Golden Girls. And the reason I bring this up is I recently diagnosed a CF in a patient in her, I believe, her 70s, like last month. Um, so it's interesting because she was actually referred by our ID colleagues because she's had a long-term history of MAC, and they were following her for that. But as many of us know, what's the etiology that's behind the MAC, or what is the risk factor for that particular patient being predisposed to developing MAC infection. So a lot of um, a lot of non-pulmonary colleagues are actually ordering your basic CF workup. With most of them, it's really just the CF mutation panel of about 200 mutations. And if something comes up positive, then that ends up being a trigger for referral. ID, ENT particularly. Sometimes we see this in OB, um, I, and GI actually. GI, there's a lot of GI manifestations, as you know, related to CF, and sometimes our GI colleagues also end up ordering like a basic CF panel. Um, so coming from this, going back to this patient, so she's 75 years old, never smoker, and ID ordered a mutation. Actually, they did a complete sequencing because, we've been in touch about the way to go about fully working up these types of patients. So this mutation was found, um, N1303K. Um, and she carries a diagnosis, long term diagnosis of bronchiectasis, eosinophilic asthma. She's already being followed by a general pulmonologist and is on Nucala. She's been worked up for immunodeficiency, not on replacement therapy, not needing it at least, sarcoidosis, MAC, GERD, osteoporosis, and depression. She's only endorsed one IV antibiotic course, kind of recently, about a year ago, needing only oral antibiotics about once per year, pneumonias 3 times in her entire lifetime. But she mentioned really 12 years ago, she started having symptoms of chronic cough, sputum, night sweats, weight loss. and was ultimately diagnosed with MAC. And she was treated and completed a full course of it with azithromycin, rifampin, and ethambutol. Um, I think at that time she was actually living in Florida, um, and she lives half the year in Florida, half the year in New York. She does culture persistently Pseudomonas in her sputum, and her current symptoms are primarily dyspnea on exertion, occasional wheezing, chronic cough with sputum. Um, she is on the thinner side. Her BMI is 21. Her appetite is mediocre. Um, she basically doesn't have any pertinent family history that would trigger someone to think of cystic fibrosis. Um, from an ENT perspective, she only complains of a postnasal drip. From GI perspective, GERD, no history of pancreatitis, no gallbladder issues. From endocrine, no history of diabetes. So so just to keep in mind, like, this is a lot of information, but this is pretty much how, you would want to interview someone who might be suspicious for CF, which is really like how the frequency of antibiotics and all their organ manifestations that would be relevant for from a CF perspective, the sinuses, the obviously the lungs, but also GI, pancreas, gallbladder, liver, intestinal issues. And then of course diabetes, the endocrine perspective. And on exam, she has scattered rhonchi, and this is her long list of medications. The aerobica device was so I think, sometimes one of the greatest challenges that I think a lot of these types of patients, bronchiectasis, CF or non-CF, could benefit from is just really good airway clearance training, which um, they may not necessarily get from um, a general practitioner or sometimes even some general pulmonologists. So, so like she was ordered an aerobica, but never really instructed how to use it. So that really comes down to like trying to educate them. She's on a bunch of nabs. A lot of actually like pulmonary meds that seemed like when I saw her seemed to be a little overkill, like uh dual inhaled corticosteroids. I think she was also on dual anticholinergic. It was just very like polypharmacy like, which she could have just been a really challenging patient too. She was on and off steroids. She was on Daliresp, Nucala, um, a whole bunch of things. This is her PFT. Um, so you can see it's definitely moderately obstructed um, off of the spirometry, and she has hyperinflation of her lung volumes, and her DLCO is mildly reduced. And this is her frequent sputum culture. Um, Seems pretty pan sensitive, Pseudomonas. Sometimes sometimes it's Pseudomonas is described on the sputum cultures as mucoid producing or not. The mucoid producing tends to be more of a worse prognosis, not so like a prognosticator, I guess, because it's more difficult to treat and eradicate. This is her CAT scan from recent October that showed diffuse bronchiectasis, tree and bud, thin wall cavities, primarily upper lobe predominance. Um, and here's another screenshot. A lot of air trapping. You can see the mosaic pattern and the hyperinflation. So I'm just gonna open it up. So what do you what would you order diagnostically for a patient like this after you've already had established like the PFT, the CAT scan, the sputums? Like what do you want to work up to determine the etiology behind this? You could just like throw out some ideas.
I guess like sweat chloride.
Ding 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 ding. Yes, a sweat chloride is um definitely one of them, but aside from that, there's definitely a lot more, right?
We haven't confirmed CF, correct? We're just thinking it.
Yeah, so just say you're seeing this patient, and of course, the on in your mindset you're thinking CF, but there could be something else going on, and you don't want to just rule out CF and label this patient as idiopathic bronchiectasis, right?
Mhm. I mean, I assume you'd also want to get like a sputum culture as well,
Hmm.
just to make sure there's no MAC. I guess she already had a history of MAC though.
Yeah, so I mean, the NTM infection is definitely like the chicken or the egg, which came first. So I mean, it's definitely still one of the main etiologies behind it. But again, that's just another etiology. Any blood work anyone would want to order besides besides your CF mutations?
I mean, you can go
Immunoglobulins.
globulins to rule out immunodeficiencies.
What?
Immunoglobulins.
Immunoglobulins.
Right. Right, you want to work up for immunodeficiency. You also
Maybe
want,
not in this patient, but alpha-1 antitrypsin in a younger patient, perhaps.
yeah, definitely alpha-1 antitrypsin. So, so great. So those are a few of the items that you'd want to just do. You want to be thorough. You want to see what's the underlying etiology for the bronchiectasis, which she may have had her entire life. So idiopathic is, I mean, in the literature, it's quoted as 30 to 50%, but I think it could be less than that, especially once we're finding more mutations for CF. CF obviously is one of them. Immunodeficiency we talked about. So her workup, um, well, it was negative. The alpha 1 was negative. Um, Primary ciliary dyskinesia is another top one to think about. Probably more so for the boards than in real life because it's pretty rare, but that's generally should be thought about in case. Um, COPD patients are at risk for all these types of infections, chronic pseudomonas for bronchiectasis. Again, like history of childhood infections. We talked about NTM. Also, you want to work up ABPA, um, and your connective tissue disorders like RA and ulcerative colitis. So definitely the sweat test. So I guess depending on where one practices, like for us, we send them to Cohen's Children's. I think most places it would be a children's center. But so it comes down to doing a sweat test where they put pilocarpine gel and all these little discs, and they stimulate the patient's arms, both of them, to sweat. And I don't think I have a picture here, but basically the gel turns blue as it's collecting the sweat, and then once it's entirely blue, the sleep not the sleep tech, the sweat the sweat test tech takes it off, and then measures the disc, and it would be reported on both arms. It used to just be one arm, but they wanted to do both arms because sometimes you get like tests that are like quantity not sufficient, which patients would have to come back again to repeat it. Or if the patient is dehydrated, that could affect the sweat test, stuff like that. Um, and then really the sweat chloride is measured, and here's the breakdown. If it's greater than 60, at least 60 millimoles per liter of chloride, sweat chloride, then you most likely have CF. If it's less than or equal to 29, it's very unlikely to have CF. And then the borderline is 30 to 59. So just remember, CF is always a clinical diagnosis. So you could diagnose someone with CF with a borderline sweat anywhere from from 30 sweat chloride to like 80 or 90. Like 80 or 90 is your usual delta F 508 patients there that are homozygous. It's like clear cut CF from childhood versus like the ones that are like, oh, I have a little sinusitis, I've had a sinus surgery, and that's it. So, but they could still technically have a spectrum of like a very mild phenotype of CF, and their sweat chloride could just be like 35. Nothing really impressive, but we're finding more and more of that sort of phenotype in patients now. So once you get this, we do it simultaneously just for practicality. You know, you're ordering the blood test and the sweat chloride just for practical purposes. You're seeing the patient once. You want to get the workup done. But this algorithm just goes on to like, you know, then you order your genetic analysis. And it sometimes it just works the other way around. You know their genes before they get a sweat. Um, and then you need two CF mutations, one from mother, one from father. And if there's so the other thing to know is there's there's at least 2000 CF mutations, and then there's probably X amount of unknown CF mutations. So a CF patient could have a borderline or high end sweat chloride, and you do their CF mutation analysis and you only get one mutation back on the report, and then you're wondering, well, does this person have CF or not? So that's where it comes down to a clinical diagnosis. How strong is your suspicion? How do they clinically manifest in terms of all the, you know, review of systems? And it may come down to we just don't know the second mutation for this patient, and you can still diagnose them with CF. You just have to be vigilant about being thorough in your history taking and monitoring purposes, because a 30-year-old now with mild sinusitis, by the time they're like 70 years old, they may present with that mild moderate bronchiectasis like I just showed you on the CAT scan. So and that patient has mild CF. Well, I'll get into that. So that's where it comes down to between the sweat chloride and the CF genetic analysis. Um, this stuff down here, like this is like not readily available. It's like measuring your nasal potential difference, where they put electrodes like in the patient's sinuses and they run currents. It's so, and it looks very torturous. So it's not really available, so you don't have to worry about that. So this patient's sweat test ended up being borderline. So this was in December. and her right arm measured 38 and her left arm measured 37. So it's definitely borderline. You have the option for a patient like this. The guidelines generally say you should repeat the sweat test. Um, I mean, it's an option. But they say to repeat it just in case you want more information and you're indecisive. But sometimes if you have a patient with such clear manifestations that could be attributed to a CF mutation, and what else could you offer the patient? It might not change management to repeating a sweat test. Most often, when I repeat them, you want to repeat them like maybe 2 months later, but it comes back generally the same. So what you're left in the same the status of what to do. Um, and just also to review the mutations of how they're classified. Um, so CF, we know there's the CFTR protein that is responsible for chloride transport across the cell surface membrane, and normally there's no issue if the protein's there. And class 1 mutation, the protein is not made. And here are some examples. The most common is we have a lot of patients with the W1282X. So these are pretty much like stop codons where the protein is just not created because of the stop codon in their genetic makeup. So you just don't have the protein at all. In class 2, you have the delta F508 is categorized here, where the protein is created, but it's misfolded and gets degraded, so it never reaches the cell surface. In class 3, um, it's created, it reaches the cell surface, but it doesn't function properly. So there's still no transport. In class 4, there is some transport, but it's not efficient. And in class 5, it's functional, but there's insufficient quantities. So there could be different combos of all these types of mutations inherited from each parent of a patient. So the genetic testing, again, you'd want to screen. Well, screening is with a panel, but if you want to really be thorough and understand like what's responsible for their symptoms, you should check a complete genetic sequencing, and it'll come back with basically the report will read as like a CF disease causing mutation, which tons of literature has been reported. There's good evidence that this mutation causes CF versus variants of they would call them unknown significance, VUS, which basically it may or may not cause CF depending on the combination of, depending on the other mutation that a patient happens to inherit from the other parent. And then there's polymorphisms, which are like repeats of amino acids in their genetic sequence. So it really comes down to the combination, and that's why there's the benefit of large CF registry databases. And this is technically, it's public, it's available for anyone to log in to use. CFTR2.org database. It's run by Johns Hopkins and CF Foundation. And you just basically click in your 2 mutations and it will, and it'll do a search for you and tell you how many people are registered with this specific combination. It may come up as 0, it may come up as 5, or it may come up as like 100 people. And then it'll also tell you the percentage of these patients registered with this particular combination, how many, what's their median FEV1, if they're pancreatic insufficient, um, the likelihood of them having Pseudomonas. So these are like the 3 top things that are really helpful to gauge, like, I guess, sometimes long term, looking at a patient that you just diagnosed, like what is the possible expectations of this variation of mutations. So, and then I would say, like, always do a literature search, because I've had to rely on literally like a case report of a extremely rare mutation that I didn't know what to tell a patient. It wasn't in the registry. Somebody thankfully published a case report on this particular combination, and sometimes you need literature evidence to get medications for patients against their insurances. So I wouldn't rely on just one search. Just do a literature search, and use the CFTR2 database. And then again, absence of 2 known CF mutations doesn't exclude CF definitively. You could have 1 and still have a borderline sweat, and still have a clinical diagnosis of CF. So I hope that's clear. And then something that came across as confusing when I started CF was the reports. They always also report out these polymorphisms. Like if there's repeats of thymidine, like the 3 main variants. So these are technically called mutations because they're not exactly normal, but they're the 7T and the 9T repeats are generally benign. But they have to report it. So that's nothing really to worry about, but you can also put in the 7T as a quote unquote mutation in the registry database to check against, if someone happened to register a patient with that combination. It's really the 5T variant that's considered a mild mutation, and it really depends on how it's inherited with the second CF mutation. And the most common disease-causing combination is 5T and R117H. That's considered disease-causing. And basically, this is inherited together on 1 chromosome, so in cis. So it's sometimes, not to play like genetic counselor, but I've noticed sometimes pediatricians in the CF world, they like to try to figure out if they find um, 2 mutations that's been found on a complete sequencing report. Sometimes they want to figure out if it's in cis, on 1 chromosome from 1 parent, just inherited together, or in trans, meaning literally from 1 parent each, which would go more for the diagnosis of CF. So a lot of times, the pediatric CF physicians, they end up asking mom and dad to get tested too, to figure out how it's the inheritance pattern. Obviously, it's harder if you have like a 60-year-old adult you're trying to figure out if this is in cis or in trans, and asking them, can you get your elderly parent to do a CF test? So it's not very practical in the adult world, but I mean, that's one way to go about it. By adulthood, I would think like even mild CF, you would end up having more manifestations clinically. So we like I would rely more on the clinical phenotype rather than, figuring out mom and dad's mutations. Um, and then the TG repeats is another like polymorphism that could be disease causing if it's inherited with um, a particular CF variant. So this is kind of like just to give a screenshot. If you put these in, this is what it's really a nice resource, cftr2.org. It'll tell you like this combination is unlikely versus may, or so it is a good resource to look at when you get these reports back. So we talked about that. And so this is just kind of alluding to idiopathic bronchiectasis in the past may not have actually been idiopathic. So like this was a study on pediatric patients, and they were labeled with idiopathic bronchiectasis. But there was a small percentage who had actual borderline sweat testing, and maybe if you follow them through into adulthood, you would clinically say, hey, this really looks like CF. So patient one, the complete sequencing came back. So again, the one that came off of the panel was this mutation, and it is pathogenic. And then she also came back with a variant of uncertain significance. So may or may not cause CF depending on the other mutation. So combining this knowledge plus a borderline sweat, plus, we've seen her CAT scan, her extensive infectious history. So I basically said, you have cystic fibrosis. So, you have to always be careful, and always, before you let the patient go, tell them what it means to be labeled with a diagnosis of CF, because people will quickly go onto the website and start reading CF, what it means, and they could either get very anxious, panicky, like prognosis is very poor, lung transplant, they do spiral. So you have to be careful, versus an older patient that you just said you have CF. They may be all confused, like, well, what does this mean? Some people, I have a pair of a brother and sister with CF. They're in their 70s. The brother, he's like 75, and he's just had the worst clinical picture compared to the sister, and the sister really kind of just was completely normal up until a year ago, and then it hit her that maybe she has CF, even though she clinically didn't look like her brother, and it really put her in a state of really like depression a little bit, because she's lived all her life pretty normal and functionally, up until now, where she actually has to take more medication than she's ever been used to. So there's definitely a psychological component to CF. More so, like, depending on how, you got to support them through it, I think. Socially, there's every CF center is accredited by that's accredited by the CF Foundation, has a social worker. I know you've met Katie, our social worker, so she also acts as their mental health coordinator. There's a lot of social components to CF. CF is an expensive disease to have. Insurance is, big on, sometimes like the prior auths just get so ridiculous, how the time and effort it takes to get like Pulmozyme approved, or Trikafta approved. So, and Trikafta, just I was going to bring it up later, um, was approved for several more new mutations, but more than a handful of patients' insurances haven't added it to their formulary yet for the new mutations. So you kind of have to fight insurances on that. So that's like always a challenge. And we are seeing like the reproductive, uh, I guess the positive advantages of these new drugs. Patients are doing better; they're healthier with the new drugs, which I'll get into. And we currently have like 4 pregnant patients, CF patients who are pregnant. So that's like a lot of new changes in the field of CF, um, that really we weren't seeing years ago. And this is to kind of highlight where we are in the pipeline of medications. So the main the first drug that ever really addressed CF at all in any degree was the pancreatic enzymes, because the newborns were dying within 1 to 2 years of age from failure to thrive. So that was the first clinical manifestation, not pneumonia and advanced lung disease. You had to be older to in order to develop that, to even, you know, um, um, succumb to that. So it's really the enzymes that made a huge difference and allowed people to at least survive into gaining a healthy weight. And as we know, like a healthy weight also correlates with a healthy lung function. And then airway clearance was added onto that. um, Inhaled antibiotics, tobramycin, casein were like the first inhaled anti-pseudomonal antibiotics. Pulmozyme made a huge difference in patients. And then just and all these other things that kind of led to your current standard of care with the modulators. So right now you can see like the median predicted survival age for people born between 2012 and 2017 is 43. I think now we're probably at like 47 at least now. So, you know, it's it's changing the field, and you're going to end up meeting people with CF ultimately. Um, so going back does anyone have any questions before I continue? You can feel free to stop me. Okay. Um, well, so for patient one, so we educated her on airway clearance. Um, she had a vest already. We showed her how to use the aerobica to start. We started her on hypertonic saline, 7%. We kind of reduced some of her excessive inhalers, and we started Caistin every other month. And that's generally, once you have established colonization of Pseudomonas. um, I mean, so like Pseudomonas, if you end up culturing for the very first time, you should always try to eradicate it, which is usually 1 month of inhaled tobramycin. And then you follow up and monitor their cultures. And if if it if it seems to persist over several months and you can't eradicate it, unfortunately, you may have to call it chronic colonization, at which point you'd want to start a maintenance inhaled antibiotic every other month, like Caistin, which is inhaled as trionam, or you can do tobramycin. Um, Tobramycin, you just have to make sure, screen them for um, hearing loss or ringing in the ears or gait issues, because those are the main side effects. Versus aztreonam, it's more benign, more tolerable. Um, and then the next step is really, if you know their mutations, you want to check for modulator eligibility. So that pathogenic mutation actually is covered. She makes her eligible for the newest modulator, which is Alexacaftor, Tezacaftor, and Ivacaftor. So that's the trade name is Trikafta. Um, and we educated her on how to take it. We told her this, this is not a cure for CF, but it helps to um, improve correct the protein that you make that's responsible for CF. Um, and we told her, you need liver monitoring every 3 months because it's metabolized by the liver. We want to monitor your lung function while you're on it. Um, we talked about the side effects, um, which is generally like expect 2 weeks, the first 2 weeks of chest tightness. You may have more sputum production because your CFTR protein is kind of like ramping up and working, and your cilia is actually working because your mucus is thinning, and your body's trying to like clear itself. So you may end up producing more sputum and expectorating a lot more the first 2 weeks. So people may have some symptoms of like wheezing or chest tightness, but after the 2 weeks they'll feel much better. It's not everyone though. Um, and then the complicated part about her was that I guess she has multiple doctors, and she went back to Florida for the winter, and then her ID doctor in Florida wanted to start her on MAC um, because she's been having persistent symptoms, respiratory symptoms, decline in function, unable to gain weight. But there's a lot of drug interactions with um, Trikafta. So these are things to look out for, like really the rifampin causes a lot of interactions. It's I think it's a CYP3A um, promoter. So it basically enhances the metabolism of Trikafta and basically makes it like as if you're not taking it because it ramps up the metabolism of Trikafta. So there's anytime like, or even like antifungals, for instance, um, lowers is an inhibitor of CYP3A. So people need dose adjustments. So those are like things, if someone normally prescribes them, you need to look out for it. And then you want to make sure if they're pancreatic insufficient or not, because that would warrant enzymes. And that could help also explain their weight loss and their BMI being so low. So you want to check a stool elastase. And if it's really low, then it warrants enzyme replacement. And then they're at risk of diabetes. So it's guideline to do annual OGTTs. So one of the articles that was shared was really the landmark paper on Trikafta, the phase 3 randomized double-blinded placebo-controlled trial. And it really is a game changer for patients. So the main things, the takeaway points is that it improves FEV1 on average by 14% predicted, which is amazing. It reduces pulmonary exacerbations. It improves weight gain. We talked about the LFT checks. It has a very good side effect profile compared to the older modulators like Orkambi. Um, Rash does happen in 10% of patients, so we make patients aware of that. And then long-term effects could be, people are gathering evidence towards this, but could be lowered insulin needs, which some of our patients have endorsed, excessive weight gain, which a lot of people don't like. So we may have to modify their diet so they don't become overweight and obese. So these are like the positives and negatives of gaining lung function. self-discontinuation of maintenance meds is a big thing. Like people start stopping their airway clearance or stopping their inhaled antibiotics, and we're like, no, don't do that. um, because if as long as they're still culturing pseudomonas, technically, it's still a pathogen, that could be burdensome and still prevent them from actually gaining the most benefit from Trikafta. So as of now, it's recommended to not discontinue anything. And the CF Foundation is sponsoring a study that we're involved in. It's called Simplify, where patients are getting randomized to either stopping their hypertonic saline or their Pulmozyme. And we're trying to see if basically if patients do okay and stopping either one has no clinical consequences, because the patients don't want to take all these medications anymore. They don't feel the need. They don't expectorate anything anymore. So it's very understandable because it's a lot of treatment burden. So as much as I agree with them that why am I gonna do all these nebulizers? I don't cough anything up. I have zero sputum. I mean, they might feel worse after nebulizing, so it really is like a case by case. um, and then drug interactions just to be wary of. um, these are the so this is like Trikafta is 2 pills. um, oh, this is not Trikafta, but actually, it is. It's 2 tablets in the morning and 1 tablet at night. Um, oh, so this is basically telling you how to alter your dosage adjustment if you're on these certain other medications. Um, so patient 2 this is a shorter case, but it kind of features like someone with advanced lung disease. He's 54. He was diagnosed with CF at age 9, with a very positive sweat test. He's homozygous for Delta F508. He has established pancreatic insufficiency, does well on enzymes. He has chronic sinusitis, no history of surgeries, recurrent kidney stones, which is also a CF manifestation too. That I mean, at least they're at risk of. He has chronic pseudomonas. He alternates inhaled Tobra with inhaled Eschunium every other month. Um, so he's been eligible from from early on with the modulators since 2015. So Orkambi was the first combo modulator drug that came out. So for him, it didn't really improve FEV1, but it definitely helped in reducing exacerbations. And then Symdeko, which is the next generation combo modulator, it came out in 2018, and he was switched to that. And so just the combo drugs, ivacaftor is a potentiator, and the other combo drugs along with it is a corrector. So if you think back to the diagram with the different classes of mutations, you need to correct the protein in order for it to reach the cell surface. So all these correctors, lumacaftor, tezacaftor, elexacaftor, they're correctors. And then once it reaches the cell surface, they've continued the use of ivacaftor, which is a good potentiator to allow chloride transport to effectively be conducted. Um, so then the patient, he did well on Symdeko, but he had a pneumothorax in 2018, and that required a chest tube. He did well on that, and was ultimately discharged. and he was started on Trikafta when it came out. It came out in 2019. He started on it. So this is his chest X-ray after the pneumothorax. He hasn't really had any major. So the only consequence of the pneumo, after the pneumo, he required and stayed on oxygen supplement only at night. We've checked him with ambulating oximetries, and he's fine in that regard. So that's the only thing that he hasn't really wanted, that he needs oxygen when he sleeps. And just to give you an idea, so his lung function in 2013 it's been severe for a very long time. And 35%. He's very functional. He's an accountant. Um, and he exercises too. So in 2016, when he has exacerbations, he dips as low as 19%. And then after antibiotics, he bumps back up. And then it takes some time to recover to get back to the 30 percentile range. So when he was on our combi, he didn't really improve his lung function. And then on Symdeko, post pneumothorax, he stayed at 20% predicted FEV1. He joined pulmonary rehab and started doing a lot of exercising routines, and that I think really helped him bump up his airway as a form of airway clearance. Exercise is great. And he maintained his FEV1 at 30. And then, really impressively, after 1 month post Trikafta, and continuing exercise and continuing airway clearance, he jumped to as high as 47%. And then unfortunately the pandemic happened, and then we didn't see him for a while. He stopped exercising, but he hasn't really needed antibiotics, thankfully. He remained on Trikafta. Um, so it dropped 10% points. That's the last time we saw him last month. He stopped exercising, stopped going to the gym, and he actually became less adherent to airway clearance. And I think that's really what became responsible for his lung function drop. So we kind of encouraged him to get back into the routine of maintaining some degree of activity and airway clearance. So, and the biggest challenge with someone like this, we've talked to him about transplant referral, especially after he got the pneumothorax, but he just didn't. He wasn't amenable at all. I think because it just was a shock to him, and it didn't sink in that being such a functional person, he needed to go for a transplant consultation. So he has not really made it to visiting a transplant center yet. But the second paper that was sent out to everyone was the guidelines that the CF Foundation recommends on when the triggers, the red flags of when to consider referring a patient, and what to do in terms of like annually um, um, in patients with advanced lung disease, which is, the definition of advanced lung disease is pretty, is multiple criteria. And so it kind of is based on that, you're like your judgment call. But FEV1 of less than 40% is like the hard, rule for at least lung function. Or it could be higher, but then a patient could have other things like the pneumo or hypercapnia, or pulmonary hypertension, which are also criteria for referral. So this is why annually it's recommended to do all these screening tests to see if they meet any of the criteria for transplant referral. And then the last slide, just to mention new areas of management in CF is, we touched upon diagnosing older patients with CF, caring for more patients becoming pregnant, which is always a little scary for me because, I have a pregnant patient who has a lung function of um, in the 30s or 40s, and as much as we try to emphasize, it's very, very high risk. It's what the patient wants, and so we just have to like guide them through it, versus one of our patients, actually, she just delivered 2 days ago at North Shore, and she has a lung function in the 90s, so I wasn't worried about her at all. So a lot of the modulator drugs is really what's allowing people, CF patients, to become pregnant. The thinking is behind it is that the cervical mucus is thinner, so it's more, it promotes more conception, as opposed to before the modulators. It was thick and they weren't getting pregnant. A lot of patients weren't even on birth control, and a lot of centers have reported that after starting Trikafta, there's like a spike in pregnancy, whether it's intentional or not. But there's the spike, and then delaying urgent lung transplant needs is something that that's important to bring up with patients. We try to introduce um, goals of care discussion with every patient that meets the criteria for advanced lung disease, but it's really challenging because you can't talk about transplant without talking about if they decide on comfort measures, and that's where you bring in goals of care, advanced directives type conversations. And there's also a push from the CF community to introduce palliative care as symptom management rather than, like your end of life care. So they're starting to introduce it as early as in the pediatric population. Um, and and then there's still 10% of the CF population who don't have the mutations that are eligible for any modulator. Um, so that there's a lack in care there. And one of the resources is theratyping, which is basically swabbing patients for nasal epithelial cells and sending it to a lab in Seattle, and they basically they culture it and they test it against modulator drugs in vitro. So it's really cool, and they tell you the reports of, I guess, like the potential difference they measure off of these cells, and if it looks supportive of modulator use, they can give you the evidence, like the letter, the report that you can submit to a patient's insurance to getting the drug approved. The drug is $400,000 a year supply. So, patients just, obviously it can't afford it without insurance coverage. And then a really cool study in the pipeline is nebulized mRNA for patients who don't have mutations for the current modulators. So I actually applied for this study to be done at our center. So hopefully we get picked, but it seems like a really really cool, fascinating study that we can offer to our patients as well. So that's the last slide. Does anyone have any questions about anything?
Janet, it was probably the best CF talk I have ever heard. It was really,
That was great. Thank you.
really
Oh,
great.
thanks.
Thank you. do you want to go through the questions? What do the fellows want to do? Anna Maria, should we go through the questions?
Sure, why don't we? Yeah, I think so. If everyone has time, right?
It'll be quick.
Yeah.
So, whoa. So which CFTR modulator is approved for CF patients with a single mutation of the delta F508?
D.
Correct. D. Number 2, which is not associated with use of elexacaftor, tezacaftor, ivacaftor based on the phase 3 randomized control trial?
D.
Yep. That's to be determined. It probably does to some degree. There was one paper that showed that it actually is reversing mild bronchiectasis, and the thinking is bronchiectasis is irreversible, but that was not obviously studied in 24 weeks in the phase 3 trial, but it may prove to be true in a future study. But everything else holds true for this particular study. Question 3. You are seeing a CF patient in clinic with an FEV1 of 35%. It is his first annual well visit for the year. What should be ordered?
I mean, I put B and C, so D again. I remember.
Yeah.
D.
Yep, that's D. That's
Mhm.
correct. The CAT scan is based on clinical needs. It's not a guideline. But definitely the pulse oximetry and the 6-minute walk. So 4, a patient with CF is about to start Trikafta. Which of the following statements are true?
Definitely not A.
Mhm.
Yeah, it's E, B, and C.
Yeah,
It's B and C. Yes, it's B and C. So it's E. And then question 5. All of the following meet the definition of advanced CF lung disease except, and this is
Mm.
A. Yes. Yeah, that's purely off of the guideline. Okay, great. You guys did really well.
That's great.
Thanks, Janice. It was great.
Thanks.
Really, Jen.
Yes, thank you so much.
Yeah, of course. I
Thank
hope
you,
it was
Janice.
helpful.
Definitely.
Yeah, definitely.
We will be
Thanks,
referring to the
everyone.
slides.